Good evening, everyone. I hope everyone's had a wonderful day. Everyone's staying safe and they're staying positive and faithful and hopeful. This is the third installment of the third podcast for myself, just trying to spread the news, share a little insights, and answer questions related to coronavirus or the COVID-19. So as usual, I'd like to get started with just a quick word of prayer, and then we'll jump right into this. Bow your heads. Most gracious Heavenly Father, we thank you again for yet another day and for another opportunity to gather together and to share our experiences, our knowledge, and most importantly, the wisdom that you've given us collectively. Be with us and keep us, open our minds, keep us fresh, and keep us attentive to our spirits. In your holy name I pray, amen. Okay, so what I'd like to do today is spend, again, just a few moments in the beginning talking about some trends over the last week in LA County and California as a whole, and maybe provide a little commentary about sort of what's going on more broadly and some of the impact of this crisis or infection in the United States as a whole. There's certainly, I think, a lot of rhetoric that we're hearing in the news and papers, but I think there are some really important issues that are worth repeating. Then I'm going to go right into some questions that have already been submitted and get to those fairly quickly and hopefully spend a fair amount of time talking to you live if there are questions that you all have, and you can unmute yourself with *6 or by hitting your mute button and just go ahead and ask a question. There's also a person who is hosting this, David Simmons, and David can see you by you raising your hand as well. So you can raise your hand and then I'll allow David to sort of call on you and then we'll get to go from there. So we'll jump right into this. We've talked about this before, and from a level setting standpoint of view, again, we're talking about a virus that spreads fairly asymptomatically from person to person, meaning that most people actually get this and have very little symptoms while the bug or the germ is incubating, meaning that it is duplicating or replicating itself in this body. And then over some period of time, it is now contagious. Before people actually have really frank symptoms, before then becoming frankly symptomatic, and then the person hopefully healing from their mild or severe symptoms, and then losing their ability to infect or be contagious once again. So that's sort of what we typically think of in most infections, most viruses, and even bacteria for that matter. They kind of follow this course, and the only difference being the duration or time between sort of what we talk about incubation periods and asymptomatic and symptomatic states. That's really the only difference between one infection and another infection, the different times and how people present. So on the first podcast, which was April 6th, I showed you these numbers, and what I want you to pay attention to are the numbers on the left. And so on April 6th, when we first did this, there were 16,000 confirmed cases in the United States, in California, and there were 385 deaths in California. 1 week later, we went from 16,000 to 25,000 confirmed cases, and we doubled the number of deaths of 782 in just 1 week. And so now 1 week later on the 21st, what you see is that we've gone from 25,000 to 35,000 confirmed cases and from 780 deaths to 1,280 deaths. Now this is important because they're not doubling every 7 days. It's actually taking a longer period of time to double those numbers. Now I think it's really important to remember that the number of confirmed cases, when we look at that in the media or in the news channels, that can reflect a number of different things. It can represent new people, but more than likely what it represents are people who are in fact being tested now because we have more tests available. And so that's important to not only look at the number of confirmed cases, Most of the time we are testing, however, symptomatic people, and there's more access to testing, so that is becoming a more and more true number. However, the number of deaths that are due to coronavirus are very, very real. And so those are hard endpoints, if you will, and those numbers themselves, although they're delayed, are not doubling every 3 to 5 days. It's taking more like 10 or 11 days compared to 4 or 5 days just a week and a half ago. So as you can see on the right side of this slide shows how, in fact, we're having this sort of flattening of all of the curves. Regardless of what county you look at in California, here's LA County at the top, that's clearly flattening. And that flattening means that we're slow, the rate of people getting infected is slowing down. So there are fewer people getting infected or becoming symptomatic on any given day over time. So that's the flattening of the curve. And that's very important. That means that the social distancing, the masking, all these sort of measures that have been put in place are working. But as we'll talk about this in the question and answers, that has consequences, okay? So here are just the sort of the day-by-day graphs in California. And again, you can see what those sort of numbers look like on any given day. And again, on any given day, you can have a really high spike of new cases on a given day, and those new cases may represent the availability of testing. For example, at our hospital, we're setting up drive-through testing, which we didn't have before. But if you look at the number of deaths are sort of leveling off, okay? If you look at the trends, and this is just from public health data sets, I told you last week that LA County represents about 40% of Californians who actually have tested positive, and just about half of the people who have died from this are people in LA County, with the biggest proportion of those individuals being below 65, and many of those individuals being people who have comorbidities. Last week, when I told you the number of adults, patients that were in the hospitals, we had just about 350, 400 people in hospitals related to COVID-19. This week, we have currently, like today, we have 1,300 people who are in the hospital. Luckily, we have enough capacity in all of our hospitals to take care of these patients. But it is important to just know that just in 1 week, the number of people who are actually in the hospital sick from this disease actually have more than tripled. And so it's an important thing to think about. Even though we are sort of flattening the curve, there are people who are staying in the hospital, and they stay in the hospital for 1 week to 2 weeks. And the longer you're in the hospital, that means each new infection sort of adds up. And so this coming week will be an important week in terms of trends to be able to tell whether or not we are really going to just continue to slowly increase, or whether or not we'll have people getting discharged from the hospitals, people doing better, and we truly are flat, if you will, or have reached the peak. 4% of the Angelenos we predict are sort of infected. And there was a study that was done by Public Health Department where they basically took test kits out into a convenient sample of about 860 people in Los Angeles and tested them. These are asymptomatic people, just to see how many people had antibodies against COVID-19. And they found somewhere around 4.1% of people in their convenient sample of 863 people actually had antibodies. Now, these are people who are asymptomatic, and what they did was they then applied this to a model to see how many people in Los Angeles County were likely already infected, meaning they had already gotten an infection, whether they had symptoms or not, and were now immune. And they project this to be anywhere between 200,000 and 400,000 people likely in LA County have already been infected. Now, this is important because that 200 to 400,000 is still just a fraction of the 11 million to 12 million people who are residents of LA County. And as we talked about last week, in order to get herd immunity, you need to have somewhere between, on the low end, 70, 75%, but closer to 80 to 85% of people having immunity. And that herd immunity with the right amount of people can actually extinguish this infection completely. So the idea that you have 4 or 5% of Angelenos infected is refreshing to some degree because we know we haven't taken care of that number of people in the hospital. However, we know we're a long ways away from actually having adequate population-based immunity, adequate herd immunity to actually prevent the spread of this disease. This slide just looks at sort of the last 3.5 weeks or so. And it looks at 70 hospitals in LA County. And again, it looks at the number of people that are in the hospital at any given time who have tested positive. And you can see, you know, on this graph, there are like almost 1,200 people on this graph that are representative of these 70 hospitals that are in the hospital right now. And that's significantly more than just a week ago. All right, so the point of really kind of going to that very quickly was just to make everyone sort of aware that even though we are sort of flattening the curve, there are more cases, there are more people who are still getting infected. Those people stay in the hospital for a prolonged period of time. And even though we still have adequate resources, meaning adequate number of ventilators, adequate number of ICU beds, and personnel to take care of these people that are sick, it could get worse. And it doesn't mean that we are out of the woods yet. So still adhering to the measures is extremely important. Okay, the first question, can you get infected with in COVID more than once? So this is the virus. Can you get infected more than once? And the answer to that is really uncertain. If you ask in the United States, we don't have a single person who's been reported to be infected twice. And so that is not clearly documented in the United States. We do have some reports of such co-infection or reinfection, if you will, from China. And this would not be completely without logic. What do I mean by that? Well, we know that the coronavirus is a virus like other coronaviruses that we actually have seen before that cause viral illnesses and colds, for example. And many of you on this call have actually had the cold more than once. And I would add sometimes in the same year, 2, 3, 4 times in the same year. And so our immunity for even the common cold lasts for a short period of time, and then we're susceptible again. We don't know whether or not we're going to have that same sort of immune response to this bug or not. We just don't have enough experience yet. So in theory, based on the way other viruses have influenced our body's immune system, yes, you could get infected more than once, or meaning your immune system could wane over time. But we just don't know. It is possible that the immune response could last longer than that. And we will know in the coming months, particularly with the vaccine trials, whether or not this will work. Okay? Another question. We're encouraged to wear a mask outside. So we know that the Department of Public Health and Los Angeles City Mayor both have actually put out orders for us to wear a mask as we walk around about outside. But aren't we in less danger of getting the virus being outside? And I think I would say this with a lot of confidence. Absolutely yes. Outside in the broad open spaces, we know that respiratory infections and respiratory illnesses do not thrive. Most plagues, most viruses, most pandemics are spread in enclosed areas over a period of time, and then taken from one enclosed area to another enclosed area and spread that way. And we talked about this before with droplet precautions, etc., that even with droplet precautions, we have this challenge, this problem, if you will, that the droplets of this virus have to land somewhere. And they usually are landing on furniture, on a doorknob, something that you're going to contact. And again, likewise, when you're talking with someone, it's much more likely that the aerosolized viral particles are going to be right there, kind of just hanging out between two people if they are sort of sitting or standing talking in a closed environment than if they're outside where there's a breeze or there's much more air for those viral particles to get diffused in and diluted. So yes, you're much safer outside. Many of us probably wouldn't want to sleep outside on most days. So the challenge is we do have to come inside. The stay-at-home order, however, the shelter-in-place order is really in place to mitigate not so much being outside, but it's what people do when they're outside, right? And so typically when people are outside, it's where they're going and who they're seeing. That's your risk factor. So yes, being outside is very, very healthy. And it's just a matter of sort of taking stock in where you're going. Are you going someplace where there are people who are congregated together, where one or two people who are sick can spread it very quickly amongst a crowded room, for example? And are you seeing somebody who may or may not be taking precautions, may or may not have been using good hygiene, etc.? So again, I think it's very, very important to not believe or think that being outside is the problem. It's not the problem. It's actually sort of where you're going and who you're seeing that could be a potential risk. A really good question that was submitted ahead of time was this question of, is this virus dose related when it comes to the severity of illness? And I think the person who wrote that question meant, if you are exposed to more virus at one time, is it more likely that you're going to have a more severe infection? And what we know from that actually comes from the experience with healthcare workers, physicians and nurses, where we've had otherwise healthy physicians, I mean young, in their 30s, and nurses, just very young, otherwise healthy, dying from this disease with no underlying comorbidity, no history of asthma, diabetes, or hypertension. And what's thought is that some of these physicians, particularly surgeons, head and neck surgeons who do surgery on the airway, even ophthalmologists who are oftentimes face-to-face with the other patient when they're doing their exams, may just have more intense exposure. And that very intense exposure itself over a short period of time gives them more virus that gets into their system. And we know that these young, otherwise healthy people in the population have been doing really well. So why is it that young people who may be healthcare workers, physicians, nurses, etc., are dying from this? And so one postulate has been that intense exposure over short periods of time, which typically happens when you're caring for patients, particularly without proper protection, is the risk for this. The other sort of risk for severity of illness are things we talked about before, which happen to do with risk for having complications, like having underlying lung or heart disease, being frail, elderly, or poor immune systems. And so, of course, those things matter. But it's usually the intense amount of virus and how long you're exposed to that virus that has been associated with the severity of infection. All right, I think I'm about to the last of the prepared questions, and we'll open it up to questions that you might have on the call, and I'll take them live. Are we reaching the peak of this crisis? In other words, what is the possibility of a second outbreak in the fall? To answer this question, I'm going to turn on my light. So to answer this question, I think it's worthwhile understanding that there's a difference between the term peak and wave. And so in the graph that I've shown you here, you see these different peaks. And in the red line, this is actually what typically happens with a typical epidemic or rapid spread of an infection, right? So you see a rapid rise, sort of this exponential stochastic model, if you will, going rapid rise and rapid going down. The reason why it goes up very quickly is because there are lots of people who are susceptible, right? They don't have immunity, and they're getting infected and passing it from one person to the next person. Then once you reach saturation of the population, meaning all those people who were infected can no longer get infected, then you start dropping off, right? So that's what typically happens. And that happens when there are no mitigation measures. There are no vaccines. People are actually crowded. They're just getting infected left and right. This happens very commonly before we actually have the flu vaccine. This was the model of what we had every flu. When you do social distancing and other mitigating measures, what you'll do, instead of having that typical exponential growth, is you'll flatten the curve, which is what it looks like we've done here in California. So this is this sort of green line. Now, both the green line and the red line have peaks. That's a peak. That's a peak. So without social distancing, we have a much higher peak. With social distancing, we have a lower peak. The fact that we actually go from one peak, then it goes away, and then it comes back is now called a resurgence or a second wave. And so that's really the heart of this question. If you actually flatten the curve, as we've done really nicely in California, but you remove some of the interventions that allowed us to flatten the curve, like you allow people to kind of go back to normal in terms of their interaction, their lives, how people go back to school. You don't have mitigation strategies in place. You don't have the public health resources in place to prevent people from getting infected, or even the ability to track who's getting infected. You don't have adequate testing. Then, with the assumption that you still have infections still circulating in the community, even if it's a small number. Remember, we just started with one case in January in New York, and now it's throughout the United States, right? You will have a resurgence or a second wave. So yes, it is very possible and very likely that we will have another wave of infections if we relax the mitigation strategies. The issue, and this is one of the political things I want to talk about, is you can't stay in this sort of social distancing, mitigated sort of population strategy for a long time. You just can't do that. And the one reason you can't do that that's very important, that has other consequences, is the economy. And we know that in Los Angeles County alone, we've already lost over $1 billion in taxes just because people aren't spending money. People have actually lost jobs, right? Hundreds of thousands of jobs have been lost already in LA County, millions across the United States. And that will continue. And that will have its own consequences, which is very, very important. Direct and indirect consequences of an infection. So this is where the smart people have to get together and decide what risk is best to take. And if you take the risk of opening up the economy, opening up people going out and spending money and opening up businesses and trade and interaction, importing, exporting, etc., the economy will recover, but you're likely to spread the infection again and then see a second wave. So we'll find out in May whether or not the country, as well as whether Governor Newsom in California will sort of lighten the mitigation strategies, and if so, how they'll do that, and what they will do to try to protect the most vulnerable in our population. So I will tell you that if they decide to do anything in May or even June, the chances that we'll have a second wave, given our infrastructure, is very, very likely. The last question, what should I do if I have only mild symptoms such as a dry cough, headaches, or a runny nose? Well, in this chart, you can see that a dry cough, which is very common, can be seen in allergies as well as influenza. Most of influenza is gone now. Even sneezing can be seen in different diseases, but runny nose can be seen in COVID-19 as well as in allergies. Sore throat can be seen in multiple diseases. So having these symptoms doesn't mean that you don't have COVID-19. However, it doesn't mean that you should go and get tested right away unless you are concerned about spreading this disease because you live with someone else who might be vulnerable. This is a catch-22. On the one hand, one might argue that the best thing that could happen is if you don't have high risk yourself, or you don't live with other people who have high risk, they should just go ahead and let people get infected and let them develop some immunity. And so you can kind of go on about your lives, if you will, to some degree. On the other hand, there are risks, particularly if your exposure risks someone else getting exposed, meaning elderly or frail person that may live with you or you come in contact with, or someone who's got chronic illnesses or lung disease. And those individuals, even though you may have mild symptoms, could get very, very sick and die. And so for that reason, and that reason alone, if you're someone who thinks you're at risk, it might be at risk of exposing someone else who's vulnerable, it's very important that even with mild symptoms, that you try and get tested. Okay, and with increasing tests being available, there's no reason why you shouldn't get tested. Okay, I've gone through a number of the questions. I'm going to stop and see if people have questions live that they want to pose or ask. Okay, I'm going to take off my glasses, so can't see this chat here. All right, Andrea asks, what do you think of IgG and IgM as means of tracking or screening? Well, now, my sister, who's a nurse practitioner, now she's going to ask these sophisticated questions. Well, IgG and IgM are antibodies. They're different types of antibodies. You get different antibodies, different types of antibodies at different times of the infection, okay? So, for example, IgM antibodies are what we call pentamers. They're 5 antibodies kind of stuck together. And we typically see the IgM type of antibody in what we call acute infections. We see the IgG antibody in someone who's recovered over a longer period of time. And the IgG antibody is what typically protects you from getting a new infection. So I do think that people who are looking at this, particularly for vaccine research, are looking at exactly this. They're looking at the presence and duration of IgG antibodies in people who've had previous infection. Right now, we don't have the infrastructure to test specifically for this for everybody. There are some individual test kits that have been designed that particularly look at IgG. And if we can make them reliably, there will be something that will be helpful for us to actually begin to incorporate in the community. Right now, some of the test kits that are available have too high of a false positive rate and therefore aren't as reliable. But yes, the CDC and other smart people, much smarter than me, are actually already thinking about this. Good question. Okay. Let's see. Here's another submitted question. And again, if people want to ask a question, you can go ahead and ask a question as well. And I'm okay with that. But I'll take this one as well real quick. What about the people who have other severe medical conditions that are not being treated? Great question. What I'll tell you is that the Kaisers of the world, the county hospitals of the world where I work, UCLA as well, Cedars-Sinai, they all actually are developing strategies to go back. Now that we're finding that we are kind of hitting a steady state of infection, we're finding that our hospitals are not subscribed and are overran with so many patients, that we're now beginning to plan how we begin taking care of people who previously have been really sort of delayed. This is elective surgery, even people who we've been doing what we call telehealth or telemedicine for. How do we bring certain people back to the hospital so we can take better care of them? So everyone is working on that now. What we wanted to do first was we wanted to be sure that we had enough resources to take care of this crisis and that we were sort of at a steady state before we started reintegrating our usual care. So you're going to begin seeing in the coming week or two reintegration of usual care, reintegration of elective surgeries. This is going to require people prioritizing which surgeries you should take care of first versus which surgeries you can put off still for another month or two, as well as which patients with what diseases we want to come back to the hospital versus which diseases we'd still continue in telehealth. So everyone I know of across LA County is actually starting to already begin to plan for which patients, which procedures we begin reintegrating back into the usual care. So very, very good question, and everyone I know is planning that. Okay, the next question. Does the virus have a half-life? If so, why would it resurge again? Great question. We don't know what kind of virus this is going to be in terms of its activity. Meaning, is this going to be like the first SARS virus, where we had a big SARS epidemic, if you will, and then it went away, and it was completely gone. The half-life of the virus, as you talked about, which is a really good question, really depends on its ability to find someone who's susceptible. Because remember, a virus wants to replicate. A virus doesn't want to die. A virus wants to live. So it wants to find a host that it can live in, reproduce in, and keep going on and on. So any virus that actually kills most of the people that it infects in a short period of time will extinguish itself. And remember, the MERS epidemic, the SARS epidemic had a very, very high case fatality rate. The majority of people who got infected died. With this, we know that 4 out of 5 people who get infected with this virus don't even get that sick. And of the 20% of people who get infected, only 1 to 4%, depending on who you are, actually go to the ICU. And half of those people die. So the majority of people do not get sick enough to even go to the hospital. And even the people who get sick enough to go to the hospital, the majority of them go home. So this is a virus that, even though it's a bother, it's a nuisance, only a very small fraction of those people will actually get sick enough to go to the hospital and be in the ICU and even die. The majority of the people recover and do well. And that's a virus that has a long half-life. That's a virus that will stay around in the community because the majority of people will do okay. They'll live with that virus. It's no different than the flu or the common cold, for example, where the majority of people who get it do just fine. So it stays around in the community, stays around the population year after year. And again, we won't know for some time whether coronavirus will be like the flu, the regular flu, or whether it will act more like the swine flu, for example, that we had in 1917, 18. But we do know that it's not as lethal. And because it's not as lethal, it's likely to stay in the population a little bit longer. And again, it's not until we have a vaccine or adequate treatment and the ability to readily identify people by testing whether we'll really be able to get ahead of this, like we do have with the flu, for example, where we have a vaccine, we have a treatment, and we have ability to test for this readily. So we need all 3 of those to really get a handle on this and be able to kind of move forward without actually having these waves, big waves. And then we just may, if this is like the flu, just have to deal with so many people who are susceptible who will get this disease despite a vaccine every year, and a fraction of those people dying. That's sort of the price of living with viruses or other infectious organisms. Okay, really good question. Okay. So this is my brother asking a question. And the question is, assuming you've been exposed to the virus, is there any action one can take on a routine basis that can lessen the chance of symptoms or side effects? I guess that's what you're saying. So there's really not a lot you can do except for staying healthy and doing things that promote health. So again, your immune system, for better or for worse, the way our bodies were designed, the way God has designed us miraculously, for the most part, is to stay healthy. Now, some of us develop chronic illnesses and chronic diseases, but our bodies are designed miraculously to fight infections, to survive. And so anything that might actually impair your body's ability to fight infection, to thrive, to survive, will impair your ability to fight this disease. Meaning, if you're stressed out in jobs, stressed out in your relationships, stressed out because of any reason, because you're watching CNN all day long, all those things are going to affect your immune system. We talked about this 2 weeks ago. Chronic stress, or last week, chronic stress causes chronic cortisol and other inflammatory markers in your body to be elevated, and they suppress your immune system. So a chronic stress state will actually increase your risk of having more severe outcomes or severe side effects of this infection. Having a chronic condition that's poorly cared for will increase your risk of having complications. So for example, if you have diabetes, but you're not taking care of your diabetes, you're going to probably have bigger complications. If you have nutrition, which is, we've talked about this a number of times, particularly at Normandy, there are certain foods that we know are horrible for your immune systems, like refined and processed foods and sugars, etc. Right? Just simply cutting these refined foods and sodas, refined starches and carbohydrates out of your system will improve your immune system. So there is no question that there are things you can do routinely that if you were to get infected, making sure you're less stressed, having proper nutrition, drinking lots of water, getting proper rest, for example, taking care of whatever chronic diseases you have, and going to the hospital if you need to early are things you can do that will improve your outcome. But we otherwise don't have any proven therapy right now once you are sick, other than just supporting your body to actually cure this virus. So very good question. Andrea, my sisters, it's the siblings who are giving me questions now. Do you have any recommendations for reducing the risk of infection in places such as nursing homes? Ireland has suggested throwing healthcare professionals into the system as opposed to typical medical assistants or CNAs. Just a good question. What I can tell you is that in places where people are following proper guidance around PPE and hand hygiene, the risk of infection to healthcare personnel or spreading it from one nursing home resident to another is minimal. And so when people are taking the right precautions, you can't spread this disease. It's actually really good. It's when people either don't have the proper equipment, the proper personal protective equipment, and they're not using it properly, or they themselves are not adhering to proper hygiene, that we really run the risk of doing this. And we've seen this in nursing homes here, even in Southern California. So there's a big outbreak in Redondo Beach, and we have almost as many employees have this infection early on than actual patients. And this is because the employees have it and they were going back to their break room. We see this in the correctional health system, where there are more correctional health officers who have the infection than there are inmates. So it's really about people not being thoughtful, not being wary of the proper hygiene, the proper protective strategies. I promised myself this week I was going to put a mask on just to give you guys an example of what I think are really bad common habits of doing this, but I actually have it in my car. But what I will show you very quickly is, let's say, for example, this is a mask, okay? And the mask is on. Forget this hand. This hand is actually just there. What you'll see is people, first off, wearing a mask like this, covering their mouth, not their nose. Doesn't help, okay? So you gotta cover both. And ideally, the idea that you're exposed and you're covering your mouth and your nose, but you're not covering your eyes, doesn't make sense, right? So if you're gonna be in an area where you're exposed, really a high exposure risk, you should cover your eyes, your nose, and your mouth. Okay, now what I see all the time with a mask, for example, is that people have their mask on and they're continually touching their mask, adjusting their mask. Remember, the virus is all out here on the mask. You've now taken your hand and you touch your mask. So your hand is now infected. You now take this hand that's now infected and you touch your computer, you touch your glasses, you touch your telephone, you touch things in your environment, and all you're doing is just spreading the virus around. So ideally, when you're wearing a mask, you should wash your hands before you put the mask on. Anytime you touch the mask, you should again use hand hygiene. Again, you might use an alcohol solvent, or you might go and wash your hands. But the assumption is that your mask, as you breathe in and out, are pulling in viral particles onto the mask, and your mask is infected. So this is just an example of what we see healthcare providers doing all the time. Healthcare workers all of the time are infecting, or what we call cross-contaminating or self-contaminating themselves, because they're not using proper hygiene before and after touching the PPE. Okay? So this is extremely important. And I would say for you all who are not healthcare workers, if you're going to wear a mask, and you're going to wear a mask to work, for example, or you're going to wear a mask to Trader Joe's, etc. So put your mask on. And when you take your mask off, put it in a plastic bag. After you've taken that and put the plastic bag away, hand hygiene. Okay? So hand hygiene, take the mask, put it on. Hand hygiene, go do your shopping, do whatever. Come back to the car, take your mask off, put it in the plastic bag, hand hygiene. That's what you should be doing. Okay? Hope that makes sense. The area that is swabbed in order to collect a sample for testing for disease under the assumption that this is a place where many of the viruses collect. Would Listerine be effective attacking the virus at this stage? Sure. I think many people could probably use a little Listerine anyway. But yeah, I think there is some notion to Listerine, which can be gargled, sort of like gargle and spit, or fairly hot teas, for example, gargling and spit early on might be useful. There's no randomized controlled trials for that, but it certainly can help freshen your breath, or actually even make your throat feel a little bit better with some of the herbal teas. So it's nothing that actually is expensive, and it certainly may help. So I think that that's actually fine. I would not rely on that by itself, but there's no reason not to do that. Okay?
Doc,
All
you
right.
taking verbal questions?
Yeah, let's take a verbal question.
Yeah, Doc, I'd like to know, you've spoken about antibodies.
Yes, I did.
And being immune, or having immunity. At what point would that take place? Because we don't know about being able to be immune from this virus. At what point would you declare someone immune, and for how long?
So that requires either a test that's available, right, to detect antibodies, having enough of those tests, or it requires us to have done the research on it. So now we have the information. So right now, with the vaccine trials, we're getting that information through the vaccine trials. Remember, what they're doing in the vaccine trials is that they're doing two things, right? They are taking people who've been exposed, and they're looking at the pace of play, how quickly and what type of antibodies they develop during recovery. So they're already doing that from a scientist standpoint of view. And they're actually, to understand the natural history. And in the vaccine research, they're doing the same thing. Here's a vaccine. How long does it take you to develop antibodies, right? So that takes some time to do that to enough people in the population, so that you can now have some confidence, right, of the data that you report out to people. So if I tell you, if you get exposed, you're going to be exposed, and 10 days after exposure, you're immune. Well, plus or minus 2 days, or plus or minus 5 days, or plus or minus a week, or a month. And you can only give you that data after you've done this over a population, right? You have to have enough people, maybe hundreds or thousands of people. So they're collecting that data right now as we speak. And so we won't be able to tell you that in the medical community till we have enough information and enough time to tell you how quickly someone becomes immune. That's the first part of the question. And the second question is how long it lasts. And because we're just, we're not even 2 months into this, right? I can tell you we have several months, probably at least 3 months to 6 months before we get that information where we can provide advice to people about when and how quickly they develop antibodies as a general rule, and how long those antibodies last. So I hope I answered your question.
Yeah, thank you.
Yeah, that's going to take some time. We can't do that right now.
Right.
Okay. So there is this question about people spraying masks with Lysol. That I think Derek asked that question last time. Does this work? Can it lead to complications? Overall, Lysol does work to disable the virus. And spraying your mask as a way to decontaminate your mask is not an unreasonable thing to do. What I suggested last week is that when you use Lysol to spray your mask, you need to let it air dry. Preferably, it's not a bad idea to let things dry in direct sunlight, okay? That is an effective way to kill virus, by the way, UV light as well. But you want the Lysol to be completely dry before you then put it on. You don't want any fumes of the Lysol, right, when you put the mask on to be inhaled, because that can be deleterious to your own health and your lungs. So yes, if you want to spray the mask, that's fine. You could probably reuse that mask depending on the quality of that mask a few times. But after doing that a few times, just the moisture of the Lysol, moisten the mask, drying the mask, moisten the mask, drying the mask, will actually impact the integrity of the mask. And so we don't have science on this, but most people would say that probably wearing a mask, a disposable mask, 2 or 3 times is probably enough, and then it probably should be disposed of. A cloth mask, on the other hand, can be worn and reused over and over again. But I do think it's important to, let me just say this really clearly about a cloth mask. A cloth mask is extremely porous, okay? Compare that to a really high quality surgical mask. A cloth mask is very porous, meaning that as you breathe through it, and you can do an experiment. You can take something very light, like a paper towel, okay? And put a cloth mask on, and then just suck air, okay, like, and blow, and see if sucking air and blowing will move the paper towel. And do that with a surgical mask, if you will, if you get a hold of one, versus a cloth mask. I guarantee you, and even a high quality cloth mask, that you'll be able to blow right through it. Which means when you inhale, that you're also inhaling some small particles through that cloth mask. So a cloth mask is not going to protect you from getting the virus. What it will do is it'll decrease the risk, decrease the amount that you're inhaling, yes. And it will also protect others around you from sort of projecting that virus forward. So meaning without a mask, a cloth mask, the virus may go out in the stream like that. With the cloth mask, the virus may now go in the stream like that. Okay? I hope that makes sense. So using Lysol spray, it's totally fine. Make sure it dries all the way. After probably using it 2 or 3 times on the same paper-based mask, like an N95 or surgical mask, I would probably throw it away, probably no longer any good. A cloth mask, it's fine to wear, but remember, it's not perfectly protecting you. If you're in a high-risk situation, a cloth mask is inadequate, okay? Make sure you wash your cloth mask in hot water, soapy hot water, and dry it between use. All right? Any other questions?
Yeah, Doc, you actually missed a question on the chat. Someone was asking if it's okay to date.
I didn't see that. Really?
Yeah.
Someone asked what?
Is it okay to date now while we're in this period of being sheltered in place?
Oh, that's an interesting question. Are you living with your date? Because so that's a really interesting question, right? So there's dating someone that you already know, and someone that you trust, and someone who you know that when you see them, that your risk of actually being exposed to dozens or hundreds of other people because you don't know where they've been is very low, right?
Right. Right.
Versus dating someone who is new, where you don't necessarily know where they are, or where they've been, or where they go, right? You just kind of get to know them. So I think that, you know, dating itself always has its risk, right? Dating, meeting someone new always has its risk, even in a non-coronavirus setting or situation. So you always have to kind of do your homework, and you want to make sure you get to know someone and know a little bit about them, what they do, where they're around, who they're around, etc. But particularly in a situation like this, you have to be even more safe. And so say that you've met someone, you've talked to them over the phone, you've FaceTimed them, you've developed some rapport with them, some trust, and now you're just itching to spend some time with them. Well, there are ways to do that relatively safely. You know, you can get to know someone and see them face to face in the same room or in a park or someplace where, preferably outdoors, where you do have a lower risk of contamination in the same sort of stagnant air. You can wear a mask, or should wear a mask, to decrease your risk of contaminating them or them contaminating you. Those are all things that I will do to mitigate the risk. Again, you know, someone asked this question and in a site, and they didn't use it as the question as sort of general terms as date, but they simply said, hey, you know, I'm single, and I don't know if I could actually be alone, you know, physically even be alone for a year. You know, I got to meet you. It's just not natural. And they answer the question the same way. You know, everything is sort of risk versus benefit. And you need to think about the risk of being either alone or lonely or not developing relationships, etc., against your risk of getting infected. And so I think there are things you can do to reduce your risk, getting to know the person, making sure that you keep the environment as safe as possible, and making sure that when you are together, that you're using the utmost of hygiene as possible, particularly to control the risk of infection in your environment and with each other. But it's a really good question. It's a practical question that people are really dealing with, right? And it's not just dating, but maybe going to see your friends or visiting a friend.
Same with family members too, Doc?
Yeah, it's the same. It's the same thing. You know, like I have family members. I have some of my family members I haven't seen in some time. And when they come, those that do come to my house, you're going straight to the bathroom after some hand hygiene at the door, right?
Right.
To wash up and all the other stuff. And then we, you know, like clean the rooms, clean the common area environments before and after they come to keep them safe, as well as to keep ourselves safe. So I think that there are things that you can do to reduce the risk, but you can't make that risk zero. And I think the idea that shelter in place means that you need to be a recluse, a complete recluse, is not only not practical, but again, risk benefit wise, you're increasing your risk of depression and isolation. You know, FaceTime is nice, but it's not the same thing as human touch or being in the presence of somebody with their energy. So I think it's a really practical, important question.
Uncle Daryl,
Yeah.
I have a question. So I just got an update from my school saying that based off of the numbers that, you know, are going to be happening in the future, they're unsure, but tentatively they're deciding that they're going to be starting next semester, the fall semester, online.
Sure.
Do you see this changing, or do you see this as being most likely the reality?
I think people are planning for that to be reality for a lot of places. The two reasons why, right? One is what we talked about earlier, this whole idea of if they open things up, there could be a second wave, right? So no one wants to have a second wave at a school and then be responsible, right? That's a huge liability. That's number one. So they're kind of waiting to see what happens. Number two is it's hard to plan virtual education, and might I add, really good virtual education, right? At a moment's notice. And so if you are going to do it and do it right and make it worthwhile, it is super important to begin planning for this and adjusting for this months and months in advance. So I think that they have to plan and tentatively plan and announce this way in advance. Even if they change their mind later, it's better to plan and do this early than to wait till the last minute. But we'll see in the months of May, June, and July what really is kind of going on, both nationally as well as internationally, right? It's not just what's happening in the United States, but it's actually also what's happening in Singapore and China. Remember, in Singapore, they're already having another wave, right? So Singapore peaked, went down. Everyone was bragging about Singapore. Now Singapore is back up again. And they have more cases in a single day than they've ever had before. So people are going to be watching the behavior of this virus as we go along. And remember, I'm going to go back to this. There are 3 things that you must have in place for us to be able to move forward with confidence. You must have ability to test people readily. You must have an effective treatment. And you must have a vaccine. We have none of those right now.
Dang.
Okay? So we have some testing, but the testing isn't so widely available and cheap that we can get tested on any corner. So testing is like halfway there. But we don't have effective therapy, and we don't have a vaccine. And you really need all 3 of those before you just sort of say, let's open things up. I hope that makes sense.
Yep, did. Thank you.
Yep.
Dr. Harrington,
Yes.
question was missed, or maybe I didn't hear. What about the environment at the hospital? All these COVID people are there, and so we know the virus is there. So what would you say to some people who are afraid to go to the hospital now for treatment?
Yeah, so, you know, my nephew just went to the hospital the other day. What I'll tell you is that in general, the hospitals have taken really, particularly even in emergency rooms, right? Patients are taken, they are segregated from other patients. If they have symptoms, people are screened before they're even allowed to come to the hospital oftentimes. They're segregated if you have symptoms. Once you get into the emergency room, you're in isolated negative pressure rooms, etc. So I think that if you're sick, particularly if you're very sick and you need attention, the worst thing for you to do is to stay at home. It's the worst thing to do. So if you're sick with COVID infection and you're sick enough where you're short of breath, you should go to the hospital, 100%. If you're not sick with COVID-19, but you know you have heart failure or diabetes or cancer or any disease that is sort of getting out of hand where you need treatment for that, 100% you should contact your provider and seek care, which some of it may be able to do over the phone as telehealth, but some of it may require you going to the hospital. And so, yes, there is virus at the hospitals, but I will tell you, the majority of people who are getting infected are not getting infected from the hospital. They're getting infected in their communities, right? So yes, there's infection in the hospital, but once people come to the hospital, we're not perfect, but we're pretty good at protecting people from getting the infection at the hospital, okay? And the highest risk of people getting infected in the hospital, once you're in the hospital, isn't patient to patient. It's patient who's infected to doctors, patient to dietitians, patient to nurses. Those are the people who have the highest risk once you're in the hospital of getting infected. Not another patient, not a visitor, but people who are taking care of people who are infected. That's a really good question, but I would encourage people if they're sick to go to the hospital.
Doc,
Some of you may hear in the background people clapping and yelling on my street at 8 o'clock every night. they started this whole celebration. People, music, clapping, etc., just trying to celebrate life. It's a nice thing, but it's slightly annoying. Okay, what else? Anything else?
Yeah, I was going to say you talked about the effectiveness of a cleansing, if you will. You talked about a study where, or some experiment where they had a room that had COVID. They cleaned said room and pretty much cleaned the virus completely out of that room. How come we don't hear a greater emphasis, knowing that this sort of basic cleaning can rid homes and areas of the virus? How come we don't hear more of an emphasis on cleaning techniques to rid our surfaces and things like this? And would you stress doing that on a daily basis to make sure that there's little contaminant in our homes, offices, cars?
Yes, I think that's a good idea. I mean, there are a few logistical issues, right? Like one is panic, right? And how people respond to panic versus just common sense and information. So I told you last week, is very, very true. I would not change that. And twice a day here in my home, we clean level surfaces. And part of the reason why we're doing that is because, we have people coming in and out, meaning like I still go to work, my wife's still going to work. The kids, for the most part, have been on the lockdown. They might go out in the car, but they're not going out walking around too much other than just, I take that back, they may walk, take a walk or a jog. But the point is that, yeah, there is some risk of taking stuff that's in the outside environment and bringing it in. But the habit that we should really be thinking about is this notion of creating a sanctuary, right? So I create my house. My house is clean. It's not perfect, but my house is pretty clean. And once or twice a day, but most of the time twice a day, I start off clean in the morning, and after dinner, we've cleaned and wiped off that, wiped down everything, okay? In the meanwhile, if I go in and out, I'm washing my hands. I have a dirty pair of shoes that I leave outside. If I actually have to go to the hospital and deal with patients or anything like that, I'm changed in my office into those scrubs and all that. And then I dispose of all that at work, right? So I think about how I can minimize contamination where I know might be an infected environment. The mask I use if I go to Trader Joe's, it stays in my car, right? I don't bring that into the house. It stays in my car. When I get into my car, I, again, try to keep my car fairly sterile as much as I can. So if you have this mindset of sort of sanctuary or keeping places sterile, like your house and your car, then that means that you're doing hand hygiene before and after, right? You're wiping surfaces down once or twice, and that's the best you can do. Everything else will pretty much die. I wouldn't say any more than that. What happens if you were to get really public about that? You can imagine the hysteria the average person may have, right? Just think how people reacted to the New York Times article talking about the study of how far the virus goes when you're talking, right? It went crazy. I mean, we had people in stores yelling at other people for, being in line six feet away without a mask. We had someone drive up to a friend of mine. They drove literally up to In-N-Out. Okay, not In-N-Out because I was at In-N-Out with my son, but someone who drove up to a fast food, and the person working had a mask on and gloves. The person in the car did not have a mask on. And the person literally working was yelling at the customer because they didn't have a mask on.
Wow.
Right? At a drive-through. So, which is completely it's not rational. There's no way that that's a high risk for somebody.
Okay.
situation. But the fear that's now been concocted because of the way, you know, this sort of knowledge and this sort of information has permeated, you know, through society and has sort of preyed on our fears, unfortunately, is making, you know, some of this very difficult to just sort of live with each other and get along with each other. So I think we have to be very careful, right, about, you know, how we use information. But that's what I would suggest practically for people to do. All right. We've had a good conversation. Hope people have learned a few things. We've had some really great questions. As I was preparing for tonight, earlier in the day, I was thinking, man, there won't be that many questions. We've kind of covered a lot of things and probably not much to do. We probably only have 10 or 15 minutes of information, but it's an hour, just over an hour of information. And I feel like we've covered a lot of important topics. So thank you all for your interest, your participation, and for the great questions. And
Daryl,
yeah.
I have one last thing, and this may be a question that I could probably sit and think about, but I just, you know, if I could even piggyback on maybe what you're sharing, because I mean, we're hearing it in the media.
Sure.
And, you know, I'm doing a lot of telehealth. And so now, you know, occasionally, you know, I'm probably talking to someone who's like, okay, now we didn't have the surge. It's not really a big deal. And so I'm over it. You know, is this really real? How do you, I don't know if you're confronted with any of this, because you're probably not doing patient care as much.
No. Yeah, I am, but not deeply as someone every day, but I still see patients, yeah.
No, but I'm just in the doubt, I guess, that is now beginning to surface because we really didn't have maybe the surge that we expect. I'm even hearing it in some of the Zoom meetings that, you know, I have with my colleagues, you know.
Yeah. So I guess, you know, Andy, this is human behavior, human experience, right?
Yeah.
Like when this first started, this was going on. It was in the news. Like, you know, I've shown this in some of the talks that I've given where Kobe Bryant is front page news, and on the left of that is a whole article on coronavirus. Okay, and so everyone was talking about Kobe Bryant, but coronavirus was in the newspaper. Okay, if you watch CNN, they were talking about coronavirus in China left and right, but it was just a Chinese problem, right? Even when it hit Europe, it was a European problem. It wasn't a U.S. problem because we only had, you know, 1 or 2 cases, right? So there's a tendency, because this is how we handle fear psychologically, to minimize, right, potential catastrophes sometimes when it could affect us. That's a coping mechanism. And I think that's what happened very early on for us. Now that we've had this chronic readiness, this chronic, oh my God, look what happened in New York. It's going to happen in LA. Now it's not happening in LA. One of the ways we're going to cope with that is to once again go like, well, that was in New York. It's not in California. So we're treating New York like China or like Europe. So that's normal psychology to cope with stuff like this. And I get that. And I wouldn't minimize that because these are still people, remember, who are still afraid. So you have to remember that even if someone's minimizing, the minimizing is a way to deal with their fear. So never dismiss someone's minimization or try to talk them out of it. What you really need to deal with is try to understand that this is how they're trying to cope with their fear and then address the fear that they may actually have, even if they're in denial. What I will tell you is that you're going to hear in the next week or two, I guarantee you, from public health people, that they're going to be trying to balance what we do with the consequences of shelter in place being prolonged and its impact on the economy and people and people's lives, unemployment, people homeless, people dying because of the economic impact, versus trying to save some lives by having all these strict shelter-in-place measures. What will be the short-term consequence of doing one versus the long-term consequence of the other? And people smarter, more responsible than me are going to be making these decisions. And then we're going to have to live with the consequence of that. So I can tell you, this is not just Trump talking about we got to open it up by Easter, etc. People have been thinking about this for a few weeks because they're seeing the effects of this on society, on the economy. And we have Americans, regular Americans, who are sick and tired of being locked down. And because we actually have a First Amendment, Second Amendment type country, right? Free speech, and I'll go get a gun type country. This is the type of place where the citizens are putting pressure on their local politicians, their local leaders. You've seen this in Michigan, right? You've seen these protests around the country that are starting to happen. I mean, a protest in freaking Oregon, okay, about locking down. So people are thinking hard about how they're going to balance some of the things that we know work, but will prolong its impact on the economy and people versus opening things up. And so more to come on that. By the time we talk next week, I guarantee you there'll be even more about this. Okay?
Daryl, may I piggyback on what you just said? I wanted to just make this point. Andy and I were talking about this earlier today, and I agree with you 110%. We should never minimize a person's fear. There really is no way to even rationalize with somebody who is deeply troubled and fearful of something happening to them.
Yeah.
But the truth is, on May 3rd, there were 11 deaths from coronavirus. And today, there are 44,000. And I look at it like what has happened in LA is simply because we started mitigation strategies a week before New York did. And that has had an impact on how many deaths we've seen here. I don't know any other way that we can explain that other than, yeah, there hasn't been a surge, and we should be grateful for that because we did what was necessary to do.
Yeah, so
and it's scary that we're going to start moving back in to the economy. The economy's got to work, but I shared this earlier. I think it's they're gambling on Darwinianism.
yeah,
You make
maybe.
it, you make it. You don't. As long as the hospitals can sustain the increase in infection, the economy is going to take precedent over lives.
Yeah, well, I don't disagree with that. I mean, you said a number of things, but the two things I'll underscore. First is I agree. There's a real reason to be concerned. This is not a trivial problem. Even if you look at having a population of 350, 400 million people in the United States, if you just think what is 44,000 of that, and you think about the number of people, a lot of ways people look at that, right? In the same period of time, we lose 30,000 from the flu, right? There's no way to minimize the 44,000 people who died from this, and probably the tens of thousands more who will die from this. And that's with us trying to take the necessary precautions. But I do think that from a science perspective, from an epidemiologic perspective, the media has really clouded a lot of stuff up. And we don't have time on this call to really get into it. But what I will tell you is that there's a reason why, just under half of the cases are in New York and New Jersey in the entire United States. And it's not because of the shelter in place orders and all that. That's a small part of it. epidemiologically, the biggest reason for this, which people don't like to talk about, has to do with the system of care in New York and the system of living in New York, if that makes sense. And so if you just think about the density of the population, the density of the types of people in New York who are at risk, who are getting affected, particularly in a couple of boroughs like Bronx and Brooklyn. You know, if you look at Staten Island has the least, but Staten Island also has the least type of congregate housing and a different population demographic than Brooklyn and the Bronx. So when you start like really looking at things differently on a sort of a global level epidemiologically, there are reasons why a place like New York and New Jersey have so many more cases and why things spread so much more rapidly just in a week time there compared to a place like Los Angeles. The social distancing and all that and the hygiene, all that's important. But the bigger reasons for us and the bigger reasons for even other places like Minnesota, et cetera, and other places is actually our geography, the layout, and the density. If you look at California, and maybe next time I can show you some of this, when you start looking at California, look at where we actually are affected in California, it's actually about density and types of people living in certain areas that are highest risk. And this is why I show you guys the data that it's not just the over 65, it's the 40s years old, the 35, 40s, and 45-year-olds, particularly who actually are at risk because of comorbidities, because of the economics of their living situation and access to care. But it's a big issue. And I agree with the second point that people are thinking about there is always a risk of profit over people that you have to worry about this. But there are some people who are thinking about the economics from a people perspective. And I think we just have to kind of wait this out to see how that conversation emerges. So it's really, really important, really, really important. And I would not be the first or the last to say that I think we still have a long ways to go. And I think we still need to be careful and protect ourselves and each other. And so I'll leave you all with that thought. And again, thank you for taking the time. Thank you for the conversation. And maybe next time, again, I would suggest if you guys have questions, maybe what we'll do is limit I'll pick maybe 2, no more than 3 questions to answer as pre-formed questions. And then we'll leave the balance of the time for conversation, for you guys to share thoughts, opinions, or ask questions. And we'll move sort of in that direction. So again, guys, thank you all very much. And be very, very safe as we move forward. And with that, let me close with a short prayer by your heads. Kind Heavenly Father, we thank you again for giving us the opportunity to spend time with each other, and exchange with each other, an opportunity for us to share our wisdom and our experiences with each other. And I hope that each one of us leave this conversation with more knowledge and more information and more ability to share that and spread that with someone else. Most importantly, dear Lord, I ask that you would help us all to not just reflect on the disease and the burdens that are actually being projected through the media and through our surroundings and sometimes even through people, but to reflect and actually reside in your love and in the peace that your love provides us, knowing that you will not only care for us, but you will guide and protect us, knowing that it is our faith, our active faith in you, that ultimately can bring us the serenity and protection that we really need. So thank you in advance for what you've done and for what you will do. In Jesus' name I pray, amen. Okay, thank you all very much.
Thank
and,
you.
talk to
Thank you,
next week.
Joe.
Yeah, thank you.
Thank you. Thank you.
Thank you.
Awesome, bro.